please start your.
Okay. I'm Michael Rulo. I'm a pediatric dental specialist. The clinic is in Hamilton. It's formerly Dr. McIsaac's old clinic across from St. Joseph's Hospital. I did my training at Western for dental school, and then I did my specialty training in hospitals in Ohio. And my particular focus in treatment and specialty sort of training that we did in the US was very strong in behavior management. So the use of sedative techniques are used as adjuncts to how we treat patients. However, a lot of the old school training in pediatric dental, in the pediatric dental realm, was very physical in the past. And now we are starting to get people who are more behavior specialists in terms of behavior profiling and teaching children how to do things awake with milder sedatives. And it's a long-term, much better outcome because they're able to seek long-term care without fear. So I deal with a lot of high anxiety types, special healthcare needs, and children as a whole who have trouble dealing with just a general setting. And this talk is sort of just an introduction to pediatric oral assessments, and then we'll touch on the tethered tissue topics near the second half of it, okay? So with any assessment, you're going to start off with a medical history, and I emphasize this because children are at much higher risk for emergencies and crises during treatment, a lot of because there's going to be medications or sedatives that are going to be involved when they come for care. So screening children for being premature is a huge one. People don't realize the physiological changes that are present in someone who is premature. So anyone who is on a ventilator at birth, they're at risk for having bronchopulmonary dysplasia. If they're intubated with oxygen, obviously as supplementation, they're going to have some lung fibrosis potentially. They'll have less surfactant and surface area for gas exchange, higher risk for laryngospasms, and impaired hepatic and renal systems, which will alter their drug metabolisms. People with syndromes, and then what medications are they taking? These are all going to affect how a child's going to perform when they're sedated, okay? And these will put them at much higher risks during treatment or sedation. General exterior extraoral anatomy is important because it's going to give you a clue as to what other problems you might not have diagnosed or are underlying. So always look for symmetries. If you see asymmetries or things that just don't look right, so level of where the eyes might be, the ears, if you see them on a lower set, bone growth disturbances, hypoplastic structures, so the maxilla, the upper jaw, the mandible, the lower jaw. If any of these are hypoplastic in that they did not grow to their full potential when they should have, you're going to have other issues, particularly potential breathing issues. And this sort of ties in with a lot of these issues that you're going to see with these tethered tissues and the babies. This may be a problem and it might not be the soft tissue. Okay, if you have a retracted maxilla or a mandible, that's you have a smaller airway. Okay, growth disturbances, if you see these, suspect it's part of a bigger picture. Okay, it's unlikely you have one problem when you see something off. Check their skin, so dermatologic problems, and I see this a lot. You'll see little patches of discoloration and be suspicious if it's purplish, pink, red. You may have hemangiomas that weren't diagnosed. You may have blood vessel malformations, and these are very high risk for dangerous bleeds if they're of a certain type. So you don't want to ever be cutting into anything that has a discoloration suggesting it's a blood vessel malformation. Clefting, those are pretty easy to notice when they're big. You'll have them on the lips or in the soft palate or the hard palate on the inside of the mouth. This will, of course, affect feeding. I mentioned just some general tumors. Those are much more rare. Epulises, which would be kind of in the anterior region on the upper jaw. Check their lip mobility. Some children have just a tighter oral musculature. And again, it may not be necessarily the frenum inside, it may be the entire musculature as a whole. So sort of assess the tightness and their ability to, when they open their mouth, what are their lips doing? What are their lips doing when they're sitting there at repose doing nothing? Are they mouth breathing? Are they nose breathing? Are they lip competent? Can they close their lips with an adequate seal? Okay, so mouth posture at rest is very big and will affect the other tissues. So someone who's mouth breathing, their tonsils are going to constantly be exposed. A lot of bacteria, a lot of drying. They're not going through the nasal passage, which is going to condition the air. And a lot of these kids will get hyperplastic tonsil growth, okay? And that will affect the way they breathe. Intraoral structures, so the mucosa, which is the softer pink around kind of your cheeks. Alveolar process is the bone where the teeth attach to. If you ever see little white or yellowish bumps, and those can be anywhere on the ridges where the teeth would come out, anywhere on the palate, at the roof of the mouth, those are benign structures. They will shed more than likely, and they're just remnants of other tissues that will form into teeth or salivary glands. They're just remnants of those tissues, so they're not to be alarmed. Cleft lip, cleft palate. The most mild and undiagnosed would be a submucous cleft. And even though they look like they don't have a clefting inside the roof of their mouth, if you had a light to shine in there, it'll be a little bit more translucent. And that just means that the palate bone did not close all the way. And you just have a soft tissue closure there. Okay, similarly, a bifid uvula, which is the little stringy thing at the back of the throat. That's essentially a very mild form of what would have been a cleft palate. Tonsils, check how big they are. The Brodsky scale, if you're aware of that, just grades how much lateral blockage you have from the tonsils inside the oral cavity. And that really just affects kids who are predisposed to sleep apnea. And it has intubation risks as well. Okay. Salivary glands, make sure they have adequate saliva. And then lastly, you can check the frenum. The frenum attaches the lip to the jaw or the tongue to the floor of the mouth. Okay. There are other frenum in the mouth, but for our purposes, they're not as relevant. When you do your examination techniques on infants, I'm not sure if the medical practitioners do the knee-to-knee exam as well, but if not, it's a very useful technique. You have a much better view of the oral cavity from behind, and it's a lot easier to stabilize the child. Okay, so the bum of the baby is going to go as close to somewhere stable like the belly of the mother, and the legs you can put around her hips, okay? If they're too small, they're not gonna fit that way anyway, so, and they're not gonna struggle much, but have them kind of on the mother's leg, and then they lean backwards on the practitioner's leg, and then you can look inside. It's much more efficient and very easy to do. So with respect to the frenum, so the first one is the upper lip frenum, the maxillary labial frenum, and this is ultimately a vertical band of tissue. You can all see the pictures? Okay. It's a vertical band of tissue that connects the upper jaw to the lip. And it's important to understand this is normal anatomy, and I cannot stress that enough. Everyone should have one of these. There are some syndromes that don't have these, but for the most part, you should have this. Class 1, there's three classifications. I'm not too concerned about the classification type, but just understand where they attach and kind of the severity of that. Class 1 would be the least attached, if you will. It's going to attach before, if you can see my mouse cursor, before this band of pink. That's called attached gum tissue or attached gingiva. So it attaches before that. That's a class 1, the most mild. Class 2 would attach onto that band of pink more attached gingiva. And then class 3 would attach into where this little V is. Can you see my mouse? Okay, where the V is, that's the papilla. So class 3 would touch this papilla here, and on an infant, you would see it would attach where the teeth would be. And then a class 4 is going to go beyond that onto the roof of the mouth. It's called the incisive papilla area, but it's going to go beyond where the teeth would come out. Okay, and that's a class 4. That's the most severe. And what's interesting, if you look, there were studies on frequencies. The most common is a class 2. The second most common, I'm going to go back a page, is the class 4. So the majority of children, not the majority, a very large portion of children are going to be born with what looks like a lip tie. Now, if it's the majority or a very large percentage of people, you're not going to call that a pathology. Okay, this is normal, and it's important to understand as your jaw grows, it's not going to be the way it was when you were born. That attachment is going to start to progress, for the most part, upward and away from the roof of the mouth. So it will become less severe. So with age, these lip ties, a lot of them will dissipate. Okay, so it's important to understand what is actually a lip tie and what is the problem? Is it even causing a problem? So if you do have a lip tie, it can cause some speech dysfunction in the future. Pain on eating. I've had some kids who they can't eat an apple because it's too tight there. Aesthetics, teeth will typically, if it's severe, will grow around it. And you actually can feel a clefting of the bone because of the tension. The bone there will have a little bit of a cleft. So the teeth will come in. It's called the diastema. It's a space in the front teeth, like Madonna has. Inability to clean in the area because it's sensitive and because the tissues are overlapping the teeth. So you get an increased caries risk, which is cavities. So I think these are the bigger issues. The breastfeeding, it's a much less of an issue, and there's the data is very inconsistent. So I wouldn't use lips as a go-to if you have breastfeeding issues. For the most part, lips that are released are because of inability to clean or pain for the most part, or they have a space and it can be done later. There's no rush to do lip releases. It's very limited on what you need to do there. For the tongue tie, the lingual frenum, again, the frenum is part of normal anatomy. You can see, here's the tongue, and this is what is considered the tie portion. It's the fibrous tissue that connects, and underneath that is one of your tongue muscles. It's called the genioglossus. Okay, everyone has this, and that sort of controls the movement of some movement of your tongue. Class 1 would be the most severe, and these are pretty much what people can easily diagnose as a tongue tie. You'll see a heart shape when you lift it because it's stuck at the very tip of the tongue. And these kids are likely to have a speech issue unless this thins out or stretches with age. It's the most severe, very easy to see, and it will actually strip the band of tissue at the back of the teeth, and you will get a little defect there with age. So there's other dental concerns in the future for this if there's no other problem in infancy. The class 2 is less severe than that. It's pretty much not at the tip, but within 50% of the length of the ventral surface, the under part of the tongue. You won't get a heart shape as much. And then the posterior tongue ties, everything has a posterior attachment because everything has this genioglossus muscle behind it. Okay, so even though the anterior tie, you can see the band goes here, you still have the muscle. So you always have a posterior attachment to your tongue. Whether or not that's causing a tie is a completely different issue, but it's normal anatomy. The class 3 is less than 50% of the way attaching to the ventral surface of the tongue. And then a class 4 is virtually at the base. Okay, so you don't usually see a band you won't see a frenum for the most part. So the big question is there a tongue tie or not? The here's a little video. Let me know if you can't see this. It should show you how you can examine, and you're going to put your fingers, slide them from the side of the tongue, and then sort of put posterior pressure, and you'll start to see the band of tissue. If it's a posterior tongue tie, it will start to blanch. Okay, you can see the fingers are they converge towards the center, and they are pushing posteriorly and upward. So you can see there, it's a very good view there, okay? So that's how you can do a tongue exam to see kind of what type of tissue and how tight it is. So tongue ties associated with breastfeeding difficulties, nipple pain, speech difficulty, airway impairment, and that's glossoptosis or posteriorly and inferiorly positioned tongues. It could be part of that, and those will influence the airway. They will affect jaw growth. So a tongue that cannot lift to the roof of the mouth, part of the development of the inside of your mouth is because of your tongue. Your tongue forms the inside shape. So someone who's tongue-tied, they cannot lift their tongue to the roof of their mouth. If they can't do that, the tongue is not going to put pressure on the roof of the mouth. And remember, the roof of the mouth is the other side of the inside of your nose, your nasal cavity. So if you don't push up there, it won't spread laterally as you grow, and you're going to have less of a nasal airway passage than someone who has a properly mobile tongue. This is something that's sort of ignored or not known of, but your tongue forms your mouth, the roof of your mouth, and that influences your nasal passage. And it's that pressure that forces your bone to start to move sideways transversely. Okay, similar to breastfeeding issues, if you have a tongue tie and you can't form a latch, well, it may not even be a tongue tie. If you're not latching properly, you're going to swallow air, and that's aerophagia, and that can cause reflux-associated symptoms, irritability, gas buildup. Okay, the aesthetics portion is really just the tongue tie affecting speech and affecting how the teeth are formed in the gums at the back. Pain, if it's too tight and it's being forced to stretch, it hurts. And oral hygiene relates again to that band where it's touching the floor of the mouth, or the more severe ones will go to the back of the teeth, and you can't clean around there, and they can get they're higher risk for getting cavities in the back of in that area because it will trap food. In terms of how tongues affect breastfeeding, there are two sort of ways of two schools of thought on how breastfeeding happens. The first is the peristaltic or compression to push milk through the nipple out of the breast into the mouth. The second one is negative pressure or vacuum theory. This is, I mean, it depends what studies you're looking at. Linda Getty's had an ultrasound study that she did, and that sort of favored the vacuum theory. And the vacuum theory is if you press, so once the nipple is in the mouth, the tongue will elevate, compress the nipple, and on release, it's forming that negative pressure, and the milk will fall out. Okay, so this previous thought of how far the tongue can come out of your mouth, so stick your tongue out, is some people will analyze tethering by saying have the kid stick the tongue out of the mouth. That really doesn't matter. It matters how much they can elevate the tongue, not so much if they can stick it forward. And then here is just an image of that.
New ultrasound images have revealed how babies breastfeed. It was previously thought that babies use a compression motion of the nipple to push milk out. But the new images show that babies extract milk by lowering their tongue to create a vacuum. The ability to produce a strong vacuum may explain why some babies are stronger suckers than others.
Okay, so that's sort of on par with the negative pressure theory. And again, there are studies to support both. So you kind of have to keep an open mind. And so the two patterns of nipple damage, if you are suspecting a tongue tie, you can get it along the nipple or you can get it along the base. And that really just depends on where the infant is placing the nipple. So if they're able to, so the appropriate position is at the junction of the hard and soft palate. If they can get that depth, but they're tongue tied, they're going to still use more lip compression to achieve what they need to, and you get damage at the base of the nipple. Okay, so if you see that, that might be why that's happening. If they can't get the depth of latch, you're going to start to get the damage directly on the nipple itself. In terms of how to screen, you're going to, lip blistering would be indicative that they're using their lips too much, okay? Like a suckerfish. I'll show you an image of that after. It's very easy to see. They may have poor sleep, and that's tied in with the aerophagia. If they're swallowing air, they're irritable, they have the gas, or they're not getting enough milk and they're hungry. Inability to hold a pacifier in the mouth will be another indication. They're not gaining weight, of course. They're falling asleep because of fatigue during nursing, poor latch quality, reflux or colic symptoms, okay? And then that's all related to the ingestion of the air or nipple chewing, okay? And mothers will report nipple pain. And again, that pain or any of these problems don't necessarily mean they're tongue-tied. They mean that they're not latching properly. And you have to diagnose, why is it not latching properly, okay? And then you sort of go down your algorithm. So on the right, you can see the lip blistering. And this is just an image of where the freedom is on the tongue. You can see a little bit of blistering here. When you lift the lips to see how tight that is, if you don't see blanching at the base of the tie here, it's not tight. It doesn't matter how thick or where it attaches. If this does not blanch, it's not tight. Okay, so it could look very, very aggressive and bad, but if it's not tight and it's not blanching, it's unlikely causing any issues for the most part, okay? In terms of how we release them, I use a laser. Some people use scissors. And you're ultimately going to target the more posterior portion. If you just release the front, you may leave the back that's too tight as well. So you want to always release towards the posterior base of the attachment. And you're just going to, you're ultimately going to do a slight incision or with the laser, and it will start to open and it creates a diamond shape. The diamond shape means that you've opened it, and the more you go posteriorly, the more it's going to open. If you hit the muscle, you're going to have a significant bleed. If you hit the arteries, you're going to have a significant bleed. So as you go posteriorly, you have to watch where you're going. Okay, the fibrous tissues cut overlying the genioglossus muscle. Okay, so that's something to be careful of. This is just another image. You can see, you can just, if you have any of these elevators, it's always, you've got to push more posterior and then up, and you'll get that band to really expose itself. And then you're just going to do your incisions right along here. You want to always avoid going too lateral. All of the vital structures and scary structures are lateral to the middle. Okay, nothing is really right in the middle. You have arteries, I'll show you the diagrams, but you have arteries, salivary gland ducts, okay, on the side. And you should see this diamond when you're done if it's complete, okay? If the diamond is small, you can go a little bit more posterior and it's going to start to give you that bigger window, and you will release it significantly more. In terms of, so after the release is a very small portion of the problem. After you do the release, it is imperative that the parents are stretching, and stretching exercises have to happen or it will be a complete waste of time. The stretching exercises should be done for 2 to 4 weeks. You're going to get a variety of weeks based on the studies, but it's going to take them 5 seconds. Okay, you're going to do that lift that you do to diagnose the problem, that same lift with the tongue 5 times. Another one is your finger roll. You put it all the way back towards where the wound would have been, the diamond, and you're just going to roll, okay, or left to right laterally, okay? It takes the parents no time at all. It will be uncomfortable, but it doesn't take very long. You may see a little bit of bleeding because any wound that you cut on your body, if it touches, it's going to reattach. So every day that tongue, as it's down, is trying to reattach itself. And when you do the stretching exercises, when you lift it, you may see little bands of tissue that have already started to rope in and start to reattach. And that's why you get a little bit of bleeding, because you're going to disrupt those again. So it takes about 2 weeks for these things to heal. And then you're at lower risk of the reattachment. But the stretching exercises are inhibiting the healing process of reattachment. And they're also stretching the tissues, because that muscle has to stretch. It was never stretched. Muscles can stretch, and it was never stretched because it was tied down. So you're going to do these stretching exercises. You want to get that tongue mobile, and the child has to learn how to use this muscle now, because if it was tied, they weren't able to move it before in the way they can now, and it's going to be sore. Like when you go to the gym for the first time, you get sore on your muscles. Same thing with the tongue is going to happen, and that may cause irritability for the first little bit until the baby is trained. And it's sort of really emphasized the fact that you need to have a team approach on this. They should be with the lactation consultants, or whoever's their consultant helping them with breastfeeding afterwards, because they should be working on the latch, making sure that's proper, doing the exercises, making sure that the parents aren't just giving up, because it's very easy to say, oh, it didn't work, let's give up, let's go see if we can get a better release done again. Maybe that was the problem. But if you don't work on the exercises and the myofunctional sort of therapy to stretch this tongue, get it working properly, you're not going to really have much success. The success really comes down to an adequate diagnosis and aftercare. Okay, it's not so much just cutting it open. In terms of structures here, you've got lingual arteries that travel on the side, and then they come up to terminate, and those will be right near the frenum that's there. If you hit one of those, you'll probably never want to do this again, because to stop a bleed on an infant, they're not just going to sit there with your finger there. It's not going to do anything. You're probably going to have to go on the lower part of the jaw and on the inside of the mouth and hold down and hope it stops. Or you're going to be going to the hospital for it to get cauterized. But it would not be fun. No one wants to do that. You also have 2 salivary gland ducts that will exit there on the sides of your tongue. If you hit those, they'll have saliva problems in the future. You won't know, because that will be their new normal. But if you put scar tissue and you cut that duct, it's going to seal and probably compromise itself. Excess scarring, again, that's going to happen. Any wound was going to likely create a scar. Scissors will probably produce the smallest amount of scar. The lasers produce a very low scar as well. Electrosurge will produce a very big scar. So depending on what your technique is, you'll adjust your scar. And parents who are getting 3-4 releases because they are desperate, you're going to have so much scar tissue. It's a mess. Okay, you don't want to keep doing this over and over. It's not going to yield good results. Okay, and you'll see the whitish tissue after when it's scarred in that area. Hypermobility is a risk, but low, and that just means the tongue is too loose now. Infection is rare, but if they're immune compromised, that can be an issue. So your biggest problem is going to be your bleeding, scar tissue. Infection's rare. Pain is not a big deal. That will dissipate, or you're getting no benefit at all because it wasn't a problem. So the reasons for the failure are the inadequate diagnosis, reattachment because you're not doing any stretching, or you're not releasing it properly. Always make sure you go posterior enough. Okay, and you can tell because after you do, if you're using scissors, snip, do the same exercise, lift, go posterior, lift. If you still see a band forming, there's still a posterior attachment, okay? And then if it's successful, parents are going to report success, okay? Improve latch, reduce pain, weight gain, reduce colic symptoms. You know, things are going to start to diminish. Signs and symptoms are going to diminish as a whole. So that's sort of the tethering issues. I do want to talk to you about the updated pediatric guidance very briefly before I finish. It's sort of changed now. You probably know more about this because you're in the pediatric field. The medical model in Canada is that you see a specialist when you have a problem. Otherwise, you go to a lot of people just start off with a general practitioner. For the oral healthcare realm, it's a private system. There's no need to wait for a referral. However, parents feel they need a referral. The mindset is there that they need a referral or they don't even consider it. And they're at a very big disadvantage because we do 2 to 3 years of extra training in hospitals, and you get something out of that, we kind of know what's going on. It's not through volume and experiment. We know what to diagnose. You get a better result because it's a specialist. We know what the guidance is. Not a lot of people even have this guidance, or they're using old guidance. Children are now, they want to see them by 1 year or first tooth, because by the time they hit 2 or 3, which was the old guidance, we have to take them to the hospital to put them to sleep, or they're getting put to sleep in an office, which is not ideal. Okay. If you follow the news in the States, in Alberta, there was one recently. Every once in a while, a kid's dying or going brain damage because they're put to sleep for dental work. Okay. Dental work is an elective thing unless you have pain or infection, and it should not be the reason why you're going to sleep ever. Okay. It's completely preventable, but parents need guidance, and that guidance is most effectively done if it's given at birth. And part of why I reach out to the pediatricians is I want them to be on board to get these parents screened right away. They don't need to wait for a problem. Come right away. Year 1 or first tooth, bring them in, send them over. I'm happy to look at them. And we can screen what the problem is, get the parents on the right track, make sure that they know what to do in terms of oral hygiene care. Fluoride is now recommended right away because of people on bottles, reverse osmosis wells. They don't have the fluoride exposure you or I grew up with. Fluoride will reduce your cavities by 50%. Okay, so someone not on fluoride is going to have twice as many. Sorry? Oh, sorry. And the safe amount to swallow is a rice or a smear. That is 0.1. In water, it's 0.7. So it's well below what you would get in water. It is a safe amount. Of course, excess is toxic. Okay. Limiting juice. Juice is an acid. Acid causes cavities. So the pediatric recommendation, I believe, is 4 to 6 ounces a day. Make sure they understand that. Nighttime feeding, make sure they're not going to bed sitting with a bottle in their mouth, because the milk will eventually rot the teeth out. And they can be taught to wipe or use a wet toothbrush without toothpaste if they're going to do that before they go to bed. And pacifiers are okay. Thumbs are worse. So urge them not to throw the pacifier away too early, because they'll convert to finger and then you can't get rid of it. So the ideal is by age 3, and 4 is kind of like your stretch. After 4, you start to get permanent jaw deformation. Okay. But ultimately, encourage them to get screened right away. Okay. I really appreciate your time. I think that's the end for me. Thank you for having me. What kind of questions do you guys have?